بس للعلم كل المحاضرات هذه خلال 14 يوم ماكسيموم will be uploaded online على موقع International Cardiovascular Club. دكتور هادي أبو هنطش كو تشيرمان، دكتور حنا موجود، دكتور حنا مخامرة، دكتور منذر السعافين باناليست، دكتور غسان الشوابكي، دكتور رائد عقل، دكتور أيمن حمدان. أيمن أنت في كل الحلقات موجود معنا اليوم.
الله يمسيكم بالخير. Thank you very much. Thank you. It goes without saying, it's always complications attracts a lot of people to come and join us. Can we? Hello. الله يسهل على أيام زمان. Can we have silence, please? Hello.
Ladies and gentlemen, please take your seats. Our presentation will begin shortly.
Thank you very much for your help. Thank you. So guys at the door, you better either get out or get in. You don't have a third choice. Please. من وين الصوت هذا جاي؟ Well, I'm honored. Yeah, it should be. I'm honored to co-chair this first complication session of the PCI MENA with my good friend, Dr. Hanna Mathame. And it's an honor also to have with us good friends, Dr. Rasheed الشوابكي. أهلا وسهلا فيك دكتور. صديقي الغالي الدكتور رائد عقل. I don't mind you calling it schizophrenic, by the way. And Ayman Hamdan. With that kick-off, just for bookkeeping, each case will be presented by the presenter, 7 minutes maximum, please, just to stick to the time.
There's a keynote. There's a keynote lecture.
Oh, there's a keynote lecture?
Yeah, there's a keynote.
Oh, I apologize for that.
Okay.
Okay. Can you introduce Cath?
I'll go quickly.
He will introduce you.
Okay. We welcome Dr. Balbissi, Associate Professor at the University of Jordan. He's a colleague in the interventional Cath lab, and he holds the American boards in cardiology, interventional cardiology. Welcome, Dr. Qais.
Thank you, Dr. Hanna. Thank you for such a nice introduction. Also want to thank Dr. Mahmoud for inviting us and for giving this lecture and the organizing committee. Appreciate it. So, okay, today I'm going to talk about a subject that came across our minds. Actually, me and Dr. Mahmoud were talking about it. We come across this problem frequently. We talk about all these fancy stuff, all these nice stuff that we can do in intervention, but frequently we're faced by reality, which is, we don't have those toys. Sometimes we're lucky, we have them, sometimes we don't. So how can we provide a excellence without excess? How can we help our patients achieve their treatment without going overboard, especially where we want to do complex PCI in the real world? So I'm going to talk a little bit about the reality gap, then going to talk about core principles, perioperative planning, strategies to kind of overcome these problems, closing the gap, and conclusion. So the reality gap, the truth. 17.9 million have some sort of cardiovascular disease overall and worldwide. That's a huge number. And that's not just in developing countries, that's not in well-developed countries, that's everywhere. Why do we have a gap? There's some socioeconomic status issues, low income, insurance coverage problems, health literacy. Some people don't understand all the details about their health. Geographical disparities, difference between countryhood and urban places. Workforce maldistribution, concentration usually in urban places. Emergency network gaps. Healthcare policies, a very important point, which is how reimbursement happens. Are there any regulatory hurdles to prevent some of the equipments or medications? And also, is cardiovascular care our top priority, or maybe we have another issue like some sorts of infectious diseases? It doesn't mean it's less important, but again, that can create a gap. And also, of course, healthcare systems like workforce shortage, funding limitation, and also sometimes the physique or the psyche of the cardiologist. You know, when we're working in a system and you have so much limitations, ultimately you could get in some sort what we call moral distress. You feel you want to help the patient, but you don't have the tools. So this is the truth, and we should try to find a way around it. And this gap is not just for low to middle income country models. No, the US and the UK also have problems. Like the US model, there is advanced technologies, there's advanced expertise, but they have a fragmented insurance coverage. They have pre-authorization delays. The UK model, you have a universal access, which is amazing. They have very much standardized referral patterns, but they have capacity constraints and very long waiting times. So again, there are gaps everywhere. The idea is not to criticize, the idea is to try to find a solution around this problem. And this solution won't happen unless we come all together and try to think outside the box. Of course, low to middle income countries do have some issues, the advantages of, you know, like governmental support systems, but also there are certain disadvantages where these systems become overburdened with limited infrastructure. So, with this reality gap, I want you to know that we are not treating simpler disease, but we're just doing it with fewer tools. And unfortunately, this limitation does not justify to downgrade our quality of care. Our quality should continue to be high despite that fact, which creates a challenge for us. So, what are the core principles to think of while I'm approaching my patient to try to overcome this resource-limited problem? How can I be resource conscientious so I wouldn't waste these issues? So we want to maximize outcome with minimal resource utilization. And we should go by the 4 golden points. Selection, selection, selection. How I select my patient and where I should do him. Simplify. The less complex your procedure, it's better and less expensive. Prioritize. Go for where the money is. And reproducible. Also try to make always your procedure something that can happen 1 and 2 and 3 and 4 times. It's not just a one at a time, one in a shot, brilliant moment, and that's it. You have to have reproducibility. Those are the 4 core elements, core principles when I want to work in a resource conscientious state. The key point, as we say, was selection, right? And selection comes, the first step of the selection, the first point in my success is pre-procedural planning. I had my mentor at Mayo Clinic, Dr. Rihal, used to tell me every single day, Qais, set up yourself for success. Before you go into the procedure, think, how are you going to do it? What do you need? What kind of complications are you going to happen? This pre-procedural planning will save you a lot of problems. And this is where you do selection criteria. So, and when I'm selecting, when I'm kind of deciding how am I going to do this pre-procedural planning, there are few elements I'm looking for. One is clinical urgency. If it's a STEMI, it trumps everything. I have to do it, right? Then, is there benefit from it? Always I should ask myself this. Like, you know, we talked about CTO. We love CTOs. It's challenging. It's lovely. And when you open it up, you feel like a Superman. I agree. It's great. It's amazing. I love it. But did it help the patient? Is there viability? Like Dr. Raed yesterday said, you have to check for viability. Comorbidities. We should always try to make that also more objective. It's not how I feel this patient is not doing well. It's not a bad idea, yes, but the more objective through risk scores, the better you are. Resource availability, that's our biggest problem. And one way to overcome it is what we call the hub and spoke model. So you have a big major center and different spokes all over, and it refers to that center. This is a way to overcome resource availability. Systems and protocols. Very important to have established systems and established referral systems. This way, everyone gets a fair chance and there is no bias. Ethical and socioeconomic standardization, so you won't feel like you've treated this patient because he had a good insurance, while you couldn't do this because he didn't. Standardization, system, protocol. All right, so now we're gonna go to the second part. So first one, set up yourself for success. Second one is what kind of complex things I can do to try to help myself. So I'm gonna go through each complexity and kind of highlight a few things. We don't have that much time. So first of all, unprotected left main. Dr. Hadi spoke elegantly yesterday about it. I loved his lecture. But one of the biggest points that he pointed was, if I'm going to select something, is it truly a disease or not? How bad is it? There are certain risk scores like syntax that could help me whether he's a candidate or not. What type of is it? But if I want to treat it, simplify, provisional stenting better than these complex double stent, DK crush, only if you have to, simple. And IVUS. IVUS is a gold. And probably, if I want to invest money in left main, I will invest in IVUS because it helps in deciding the severity, helps in planning, seeing how much calcium, and also assessing efficacy after. And this is not me talking. This has been proven through the ultimate trial. And it's a class 2A to do IVUS. Okay? Of course, also other reproducible things, careful sizing, and good post-pressure dilation. What about bifurcation lesions? First of all, select. Make sure you're selecting the right patients. Classify, put a preliminary plan before you go in. But always lean toward simplify, meaning provisional stenting. Kissing balloon is always needed if you use two-stent strategy, but it's not needed if it's a single provisional stent and you have good flow. The other important point with bifurcation lesions to achieve good reproducibility is POT. Always consider and do POT, which is proximal optimization techniques for bifurcating lesions. You're buying a lot for your buck, okay? CTOs, we talked a lot about CTOs yesterday. So basically, first of all, I need to ask myself, is it truly needed? Is the patient going to benefit from it? Then I need to risk stratify him, see how easy that lesion is. Selection. Because if it's too complex and clearly he's not going to benefit, he needs retrograde and so many equipment, the cost is prohibitive. And you should always, when we talk about, medicine, we talk about the 4 ethics principles, which is beneficence, non-maleficence, autonomy, and justice. So yes, we want to do the 3, but justice is important. And justice is not only for my patient, for everyone. So spending money sometimes on a single procedure, while I can save 100 instead, is not really smart. So we should think, and maybe those patients, we can refer them to a tertiary center who can handle these much more. One excellent way, and has shown to improve with risk, is actually doing a CT angio beforehand. And you can see, if you are going to do some CT angios in a resource limited, some CTOs in a resource limited, try to stick with the anti-grade wire escalation. The others are very cost prohibitive and not always as successful, or you can get return of your investment in it. Also focus on patients over technology. Okay, of course there are so many different techniques. You want to invest in good wires. You want to invest in a mother and daughter and mother catheter. Then you can go for the other ones. IVUS also is a good investment. As we said, as I told you, CCTA is a good and excellent way to look and save money in planning before you get into difficult ways with CTOs. Anti-grade technique is the way to go if you have a resource limited. What about calcific lesions? Lesion assessment, again, selection. And if you want to invest, again, in IV imaging, intravascular imaging. What you want to do is you want to classify those patients. If he's a kind of mild disease, probably he can go with balloon. You can do it from the beginning. If he's more moderate, you could think of a little bit easier, more available ones like scoring balloon. You could do the body wire technique, high pressure non-compliant balloons. But if you think your patient is severely calcified and he needs atherectomy or IVL, he's beyond the budget, he needs to go to a referral center. And this has been shown also again through the Eclipse trial, which showed that if I'm for calcific lesion, IVUS makes a difference, while actually routine atherectomy doesn't. So again, spend your money wisely. Graft PCI, you want to truly size properly and go for pharmacotherapy. Proctor trial showed the biggest question is, should I go for the graft or the native vessel? Maybe the native vessel is a better solution. I'm going to skip this one. STEMI. If I want to go for a high resource thing, radial access. Make sure your STEMIs are done radial access. This way you'll save a lot of money and you'll help the patient. Mechanical cardiogenic shock. We were talking about it yesterday and how we can way to save money in these settings, go for the culprit vessel only. The patient is not stable, try to get out of there quickly. Use inotropes to support him. But if you want to use intra-aortic balloon pump, you can. Actually, it's not a bad idea. And especially, these are the niches for intra-aortic balloon pump. Mechanical complications, early initiation, less than 2 hours from shock, and that's been proven in Rescue 1 trial, mild to moderate shock, and resource-limited settings, which we are talking about. So again, complication management, the 4s that we talked about, set up yourself for success, and make sure also post-care is good, so you won't fall into the trap of needing to go again and do again the intervention and wasting again more money. Okay, so closing the gap. Here, we talked about different challenges, including insurance coverage. Universal insurance is a dream, but if you can get it, it's amazing. Health literacy, we should do education campaigns, workforce shortage and maldistribution, solutions, telemedicine, remote learning and simulation, training, capacity building, and task shifting. This is a critical point in low resource settings. Network gaps through collaborative networking, through public-private partnerships. Healthcare policies we should always work on, and funding, we could use a reuse strategy. I mean, it sounds kind of, whoa, but might be useful sometimes, and fundraising. All right, so ultimately, take-home messages. Complexity of the disease does not equal complexity of the tools. We could be smart and overcome some of that complexity through skill, training, patient selection, patient selection, patient selection. This is the key point. Set up yourself for success. And when you're going for your procedure, make it simple. Build your system, build your capacity, build your skill. That's key point to help with your care. And I'm gonna stop here. Thank you for your time. I think I'm on right on time.
Thank you very much, Kais. Beautiful lecture. I'm sure there will be a lot of questions at the end of the session. So stick around, please. And apologies that I didn't realize that the lecture was starting before the complication case as well. Let's pull our sleeves up and call upon Dr. Is Ahmed Saad from Egypt here? Mahmoud, did he make it? Ahmed Saad. Oh, Habib, كيفك? Alhamdulillah, على سلامتك. Dr. Ahmed Saad from Egypt has a complication case titled normal Cath, but not a benign diagnosis. Welcome to Amman, Ahmed, please.
Thank you, dear professors and colleagues. شكرا دكتور محمود وأساتذتي الأفاضل على الدعوة الكريمة. My case today is a little bit different. He is a 55 years old man. He is not diabetic, not hypertensive. He is obese. He presented with ischemic chest pain for the last 2 days, on and off. His hemodynamics were stable. Heart rate was 85 and controlled to 60 after beta blockers. Unremarkable. Clinical examination was unremarkable. He was having elevated troponin, and that was his ECG. We see an inverted T, deep inverted T wave in pericardial chest leads. His echo was a little bit difficult echo window with poor imaging, and was reported with mild hypokinesis of the anterociptal wall. He was diagnosed and managed as non-ST elevation myocardial infarction. He was admitted 12 hours before this scenario. He was medicated. Actually, while he was in CCU, he arrested in VF. He was resuscitated, reverted to normal sinus rhythm and stable hemodynamics, shifted immediately to the Cath lab, and that was his coronary angiography. Actually, it was shocking. It's normal coronaries. Is it a minuca? That is the right coronary. So we have to re-evaluate the patient. Actually, we did a bedside echo. It was in the Cath lab. It was really difficult imaging, but we could notice that it could be mildly dilated RV. It was foreshortened views from the apical, so we cannot measure the RV accurately. Mild TR. Also, there was a paradoxical septal motion. I think the previous echo operator saw the paradoxical septal motion and he thought it was hypokinesis. Actually, then the patient was, it was hemodynamics unstable, was decided to shift him for CT pulmonary angio, while sudden he arrested again on PEA, pulseless electrical activity, and then resuscitated. When he arrested in pulseless electrical activity, we thought the most common cause is hypoxia. He was not hypoxic actually. So the second cause is mechanical obstruction. There was no tamponade, so pulmonary embolism rose to our thoughts. So we get femoral vein access, and then we did a pulmonary angiography. That was the images. Here we see a massive pulmonary embolism obstructing both pulmonary branches. That was the left. And then again, during the pulmonary, he arrested again on PEA, and CPR started. Actually, we decided to, we were in a peripheral hospital. There was nothing there to deal with the pulmonary embolism, like mechanical aspiration or like that. So we decided to start the catheter-directed thrombolytic therapy with the available anti-fibrinolytic drug streptokinase. We started with 200,050 units bolus over the 10 minutes, and then completed the whole 1.5 million units over the next 2 hours. No, catheter directed over the same catheter that was in the pulmonary artery. And that was the final picture. Started to see the flow in the pulmonary arteries. And that was the right, again, reperfused. And the left. So our take-home message, always think beyond the coronaries. In patient presenting with ACS symptoms, elevated troponin, and hemodynamic collapse, normal coronary arteries should immediately trigger a high index of suspicion of acute pulmonary embolism. Utilizing the 226 guidelines of stratification from the American, from A to E. Here our patient is E2 as he has circulatory collapse. Advanced reperfusion categories for these patients, like mechanical thrombectomy or catheter-directed thrombolysis. Clinical clues in the Cath lab in case of difficult echo window, like the paradoxical septal motion, should rise the trigger for pulmonary embolism. Actually, also the important to have or to initiate a paired team with multidisciplinary approach to proper management of these high-risk patients. And thank you.
Thank you, Ahmed. We'll leave the discussion until the end, though Hannah was mentioning to me it would have been nice to discuss every case separately while it's hot and people still remember the detail.
Yeah, it's fine. It's fine. Our next case is with Dr. Munther Alsafin. He is a senior interventional cardiologist from Jordan University, from Jordan Hospital. And he is presenting a complication case with a perforation. Thank you, Munther.
It's a spastic lesion, not perforation.
Nope.
Okay. مساء الخير للجميع. My case is about recurrent spasm in the LAD, proximal LAD, firstly treated with medical therapy, then ended with stenting. My patient is a young patient from Yemen. He is diabetic type 1, smoker, قاعد شور. اللي ما بيعرف القات هو يعني شيء من الأمفيتامينز causing high blood pressure, causing tachycardia. It's well known that it causes spasm and it causes also coronary dissections. Sorry. So the patient presented 3 months prior to our admission in Yemen with acute coronary syndrome, and at that time it was anterior ST elevation. We will show the ECG in Yemen. The cardiac enzymes were positive. And this is the ECG. You can see that he has ST elevation in the anterior leads and in the high lateral leads with reciprocal changes. The patient was taken to the Cath lab in Yemen, and this is his coronary angiogram. As you can see, there is mild disease in the proximal left circ, significant, very ostial and proximal LAD lesion. The other part of the vessels were almost healthy. Some spasm maybe in the proximal right coronary artery. This is the guide taken. Next. They took a guide to treat the proximal LAD lesion, but at that time they didn't give nitroglycerin, just changing from the diagnostic catheter to the guiding catheter. They took a picture, wire inside the guide, but they were surprised that the lesion disappeared. So the spasm as a diagnosis was made, and he was treated conservatively at that time with antiplatelets, nitroglycerin, and calcium channel blockers. And he was advised to stop smoking and not to chew cut. So this is his ECG after the procedure without any stenting. And 6 weeks later, he developed another attack of chest pain, acute coronary syndrome. Also, he had ECG changes, same changes, ST elevation in the anterior leads, in the high lateral leads with reciprocal changes. So again, he was taken to the Cath lab, and this is his cardiac cath also in Yemen. You can see that the proximal LAD is having some disease, but there's no tight lesions. So at that time also, he was advised to continue on his current medication and to be strict on his medication. This is the ECG after the diagnostic cath. And then he presented to our hospital for checkup. He was taking all his medications. He stopped smoking and cut chewing. And his ECG in the clinic was fine. His echo was fine. So he was asked to do some labs and to come next day. Next day in the morning, he came with chest pain to our emergency room. And this is his ECG. You can see that there is less ST elevation in the anterior leads and the high lateral lead with reciprocal changes. So we decided to take him to the Cath lab to do diagnostic, and we were planning, even if we have some disease in the LAD, to stent the spastic lesion. This is the angio. Sorry. Diagnostic Jotkin right was taken, and then JL guide. The guide was not engaging well, the left main, some trick, and we went with the wire. Our wire was was going to the left circ. We kept there because we were stabilizing the guide. Then wiring the LAD. You can see that there is significant proximal LAD lesion before wiring. This is our stent covering every plaques in the proximal LAD, but as you can see that the stent moved a little bit distally, that the ostial lesion was not covered well. We took another stent, asked the patient to take deep breath, precisely locate our stent, and then inflating the stent in the ostium of the LAD. This was in November last year. Till this moment, he's doing fine without any recurrence of his symptoms. And this is rare indication to stent spasm. There's some indication. One of them is the recurrence of ST elevation in eyes, malignant arrhythmias, and resistant spasm despite of all medication and all lifestyle modification. Thank you.
Thank you. Thank you very much, Munther. We'll move on, and please stick around so that the questions will be raised at the end of the session. The next presenter is Dr. Rasheed Ibdah. Rasheed will present a long LAD stenting complicated by perforation. To seal or not to seal, that is the question, I guess.
Dear chairperson, esteemed panelists, distinguished colleagues and guests, good afternoon, and thanks for organizing committee for opportunity. Today I will present a case with probably the most feared complication in cath lab, a coronary perforation. In interventional cardiology, we all strive for perfection, but complication in cath lab or in cardiology, not a possibility, but it is an inevitability. So let's start or move forward with case presentation. Actually, we have a 48-year-old gentleman. He is known case of DM, hypertension and dyslipidemia, big 3, as most Jordanian. No previous history of coronary artery disease. Patient presented to the emergency department or room with typical chest pain, so cardiac pain. As you know, here is many fellows and students. We classify chest pain not more for typical, atypical, cardiac, possible cardiac, and non-cardiac pain. So he presented with cardiac pain, stable vitals. High sensitive troponin was negative. ECG unremarkable, although it's showed poor R-wave progression in anterior leads. And finally, echo was, the result is mild LV impairment with anterior apical hypokinesia. So based on international guidelines and our Jordanian local guidelines, which were released recently by Jordanian Cardiac Society, we adopt and adapt heart score for risk stratification. Based on heart score components, patient got 6 points, which means moderate risk. So the MACE, major adverse cardiac events, based on the heart score, within 6 weeks about 20%. So patient admitted to the general floor and started on guideline-directed therapy and PCI planned for next day. Here, the angiography for this patient, right coronary artery as routine, unremarkable. left angiography, left coronary system, spider view. And here, the mid-LED intermediate lesion. Actually, I was not totally convinced with the severity of this lesion, so I gave nitroglycerin for better assessment. We have here moderate or to severe lesion in mid-LED. Here, maybe after nitrocin. So, as a routine, as usual, we decided to go with stent implantation. And as long as there is no calcification, it's a straightforward lesion. Of note here, it's important, the patient had a CT coronary 2 years or 3 years earlier, and it was unremarkable, mild to moderate plaque in LED, but no myocardial bridging. So we chose drug-eluting stent. It was long because the lesion was long. It was 34 drug-eluting stent, 3.5. And I just asked my assistant to go in a stepwise manner for stent deployment, but he answered immediately 12. So he reached the above nominal rapidly. Then we got this picture. So after this moment, everything changed. So we are dealing now with a complication. It's a perforation clearly for all of us. So first step is to not getting in panic and to call for help and be ready for disaster, because as you know, this is a disastrous complication in cath lab. So we start, the first step is to reverse anticoagulation, to reverse anticoagulant with the protamine sulfate, 1 milligram per for 100 units of heparin. Full dose was given. We asked the patient for any allergy for fish because it's allergic drugs. Then we wait or looking for any hemodynamic instability and prepared our balloon for tamponade if needed. So after reversal of anticoagulant, we monitor vital signs for a few minutes. No change in vital signs. The heart rate was stable. Blood pressure also stable. Echocardiography bedside was obtained and no pericardial effusion. The next shot showed no extravasation or mild extravasation of contrast. A third one, no extravasation. So we decided to go conservatively with this case, not to escalate for pericardiocentesis or surgical or balloon inflation. Patient was stable, transferred for CCU, multiple serial high-sensitive troponin were obtained. We got slight elevation in troponin. Patient observed in CCU for 2 days, then was safely discharged. He showed up in outpatient clinic 1 month later with normal ejection fraction and a normal EKG, and actually he's doing well. So what did happen? So the most likely contributing factors for this complication, because the lesion is not so bad, I think it's due to rapid inflation of the balloon. As you know, we usually stepwise or slowly inflate the balloon, the stent balloon. could be also due to possible vessel overstretch or due to length of stent or distal mismatch. So all these factors can contribute to this feared complication. I don't know, time is finished. Okay. 1 minute, just I would like to thank Dr. Abdulaziz Al-Qithari. He's make our job easier today. He talked about coronary perforation. Just to emphasize that we dealt with type 2 perforation, and type 2 perforation based on Ellis classification, although multiple classification exist, but the most widely used is Ellis classification. We deal with type 2 perforation, which can be managed conservatively. So the take-home message, type 2 can be managed conservatively. Prevention is better than cure, than treatment. Proper sizing and gradual inflammation is crucial in Cath lab. Thank you very much.
Okay. Well, the last presenter, Dr. Saad al-Najjar, is not with us. He had an unexpected emergency. I think we'll open the floor for discussion. I can see a lot of discussions on the side. Can we open it for discussion?
Yes, please.
Okay. Let me just, Muhammad, allow me just one minute. Yeah, please stay there. I will just make a comment على الدكتور قيس البلبيسي. You give a beautiful lecture, Qais. I think, if you allow me, we can also, at the Jordan Cardiac Society, we can put these recommendations up front, like some kind of pathway instructions, in order to in the Cath lab, how to utilize whatever we have with the equipment we have in the Cath lab. I think it's beautiful. What do you think? I think we should do that in the Jordan Cardiac Society.
I think we should, and there's also a bit part I had to skip kind of quick through it on what are the basic settings for each Cath lab in order to handle, the complexity level. If you have backup or you don't have backup, we could put like a general guideline, and it's basically, based off the kind of combination between the SKY recommendations, but also I did get some resources from Asia, whether it's India or the Far East, and some from Africa, because those are, kind of lower middle income. So I think it's a great idea. We should work on it.
Thank you, Qais. I'll open the floor for discussion, but Muhammad Jabay has a question.
Okay, thank you, Dr. Hadi.
Yeah.
I have a question for Dr. Ahmed Saeed and Dr. Rasheed. First of all, Dr. Ahmed, in massive pulmonary embolism, which invasive parameter and management best indicate need for escalation beyond thrombolysis?
Ahmed? Actually, while Ahmed is getting to the podium, Ahmed knows that there are new guidelines for pulmonary embolism which came out just several weeks ago.
Actually, I put some slides, but I don't know why it was not there. It was not safe.
Go ahead.
هو عادة احنا يعني you have اللي هو الهاي ريسك بيشنت او اللي هم الستيج from D to E في النيو امريكان جايد لاينز، هم دول اللي بتبدا معاهم الثرومبوليتيك ثيرابي. الاي في ثرومبوليسيس هو المين، بس الكلام ده بشرط ان هو ما فيش هيمودايناميك كولابس اللي هي الاي 2 والاي 3. as long as you came to the E class او اللي هو البيشنت is collapsing يعني cardiopulmonary failure، ففي الحاله دي بتستعمل اللي هم السبيسيفيك او الهيمودايناميك سوليوشن لايك الميكانيكال اسبيريشن او even surgical thrombectomy.
Thank you, Ahmed. Second question, Muhammad.
For Dr. Rasheed, I think the best thing to avoid complication is prevention. I think I have a comment. I think the lesion, it's myocardial bridging rather than it's a lesion. And if it's a lesion, it's intermediate. I will go for medical treatment rather than stenting. But my question for you is, any difference in the management between type 2 and type 3 perforation?
Thank you, Mohammed. Regarding the severity of lesion, I totally agree with you. It's intermediate lesion, could be assessed as intermediate lesion, but putting the mild reduction in ejection fraction and recurrent visit to the emergency department and typical character of chest pain, of his chest pain, cardiac pain, we decide, unfortunately, we don't have also FFR in our cath lab. We decided to go for stent. Regarding any difference in the management between type 2 and type 3, actually there is a small margin. Yes, all depends on the hemodynamic stability. If you diagnose patient with type 3, where's the active streaming of the blood, it's no time for thinking, it's go forward for pericardiocentesis because the hemodynamic instability will go after. For type 2, I think you have a time to decide because the patient is stable, so you can observe your patient in cath lab for 15, 30 minutes until you be sure that he is stable.
Dr. Rasheed, allow me. I think you did a great job. You saved the patient. But for the sake of going to what we normally do for perforations in the cath lab, we just have to stress several points. The first point is never pull your balloon out of the stent after your inflation without just giving a puff. It takes only a part of a second to do it. I always do it. It's a routine for me in my practice because if you have a perforation, you see it, you inflate the balloon, you count until 10, على مهلك بتفكر, and you take your time to approach the patient. I think this is the first message which, in my opinion, is important. The other thing is rushing to reverse anticoagulation, with all my due respect to you, طبعا, you save the patient. This is a last resort. We don't do it as a first resort. The only time we reverse anticoagulation is for somebody with persistent hemodynamic instability, large effusion, and you cannot solve nothing around you, then you do it. But otherwise, we try to refrain from that because you can get into a double jeopardy عندك perforation وتسكر الستنت عندك MI. So we really don't rush to do it. But you did a great job. We appreciate that.
Guidelines, Dr. Hadi, it's recommended to reverse
not the first step, Dr. Rasheed.
Maybe not full dose. Dose, but
with all my due respect, Dr. Rasheed, just so that we don't confuse the guideline recommendations. Okay. We do not reverse anticoagulation as the first step in perforation. I don't know, Hanna, you agree? And
we do, and I like to give chance to our panelists, Dr. Raed, Dr. Ghassan, Dr. Ayman.
Thanks. Okay, thank you. First of all, we need to thank all of the people who presented complication on the behalf of PCI MENA. Thank you very much for being here, presenting this. Yes. You could have just hidden that and stay there and you are very happy. But you did an excellent job, so thank you first. Taking advantage that you are on the podium and you told us it is an intermediate lesion. You told us there is a proximal anterior wall hypokinesis which might be related. You did not do an IFR or IDAS to prove that, but you depended on clinical scenarios. My question to you, could this be an early form of SCAD? And this is why you got into trouble.
Actually, I don't have answer because I don't know.
Young patient coming to you, the lesion is not, it looks like one of those types of SCAD where you have thinning, tubular, smooth.
Yes.
But it is not really atherosclerotic. It doesn't look like atherosclerotic.
Could be, but he has recurrent, long-standing history of chest pain, recurrent visit to the emergency department. It excludes CAT. I thought, as I said, it's myocardial bridging, but he had CT earlier and excluded by CT myocardial bridging. So I think it's the most contributing factor for this complication was rapid inflation of the balloon. So we have rupture of side vessels or something else, I don't know.
Thank you, Dr. Rasheed.
Dr. Rasheed, you did not use balloon before putting the stent. And this is, I think, one of the mistake. You just direct stenting.
Yes.
And I think this is a bad habit. This is actually for me. There is no simple lesion. You have to put a balloon before. You have to know the size. You have to know the length. There is maybe some then you will put the stent. Even it looks to you that it is a symbol, but I think the balloon before it will maybe prevent these issues.
Thank you. We have a question from Dr. Munther.
دكتور إبداح يعطيك العافية. Good case. I think angiographically we see in this lesion a bridge. Okay, and maybe you did the decision that the patient has recurrent angina and should be stented, but maybe the perforation was sealed. Angiographically we see the perforation. It seems like type 3 perforation. It's away from the stent. But it was sealed maybe by itself because of the bridge. I think so, yeah.
Dr. Ayman, you have any comments? Dr. Munther, Dr. Rasheed?
And I don't know, I like to adapt Dr. Saad's point. I think there was a bridge, and maybe the fact that he inflated the balloon all of a sudden caused the stain looked far from the site. I wouldn't reverse the heparin. Would I have a wire in the LED, honestly?
Okay. You would or?
Would not.
I'm sorry, but let me just... Dr. Rasheed, and I would second Dr. رائد عقل يعني مجرد انك توقف وتقدم الحاله برفع لك مش طاقيه 200 طاقيه بس تحملنا يعني ما تاخذش الموضوع. بس I do believe it's just just to be consistent in our approach. When do you reverse anticoagulation, guys? It's not just seeing a perforation. You reverse the anticoagulation if you inflate the balloon. You already have a large pericardial effusion. You got the percussion ready to go, and etc. Patient hemodynamically unstable, and your options are becoming so little. However, when you are inflating the balloon, patient is still okay. It's not only me. I mean, it's there in the usual approaches. We don't rush to do it, just so that you don't get two problems at the same time with stent thrombosis. And I think regarding the bridge is mild. It's not severe, by the way. As much as the lesion is mild, the bridge is mild. Definitely هذا اللي حكى قيس على موضوع إنه we don't have equipment in the cath lab. If you had an FFR or IFR and that was negative, you probably wouldn't have stented it. So I'm sure.
The bridge, I think there's part of the muscle is, maybe صار rib في نفس muscle, not the vessel.
But on the angiogram,
because it looks really.
It looks tube-like or cylinder.
It doesn't look severe. It's not an obstructive type of dynamic bridging. اللي مبين.
On CT, previous CT report was no bridging. So.
But something, allow me to just say that rapid inflation and perforation. ما احنا جايين نتعلم من بعض يعني. If you rapidly inflate an undersized stent, you won't get a perforation. If you rapidly inflate a stent, which is a bit oversized, you might get it.
Yes.
So probably the 3.5 stent was a bit oversized.
Yes.
I'm just trying to learn from your experience.
Yes, of course.
Allow me, colleagues, please.
Please. Well, my question is to Dr. Munther. I rarely encounter coronary spasm that been treated with a stent. And the traditional thinking, we always think there is maybe an underlying cause, there is maybe an underlying lesion. Do you feel it's much better if you go? No, I'm sorry. Do you think it's much better if you did for this patient an IVUS to make sure there is something underneath before you do a stenting? And the second question is, if this is my patient personally, I will recommend an ICD because most of those patients will die from cardiac arrhythmias when the vasospasm is happen. And the question, and maybe the other question is, did this patient was optimally managed with the vasodilators? Maybe the good answer is to give him long-acting nitrates or a chewable nitrates in case if he have a chest pain and to restrain it from risk factor. So the question, do you think IVUS will be the good answer? And do you think you're going to recommend for this patient an ICD? Or at least to give him a Holter monitoring? Thank you.
Munther, you want to answer that?
Thank you. Good question. As you saw that the patient presented 3 times with ST elevation MI, and it was documented. It was documented by the trop leak and the ECG changes. And this patient was fully medicated with dual antiplatelet therapy, with nitrates, calcium channel blockers. He stopped smoking, stopped chewing cud, and despite of this, he has this ST elevation in our hospital. And there is some reported cases about what to do with these patients. There was a case with ventricular arrhythmia. The presentation was ventricular arrhythmia. And for this patient, he was transferred for ICD. Then they did Cath and they found the spasm. They treated the spasm and they didn't put ICD for this patient. It was reported in some journals. And for our patient, recurrent ST elevation MI, and you could appreciate that the proximal LAD was not healthy. There's a plaque. He's diabetic type 1. He has multiple risk factors. That's why, without doing IVUS, I think we should stent this lesion to prevent recurrence of the spasm.
Thank you, Munther. I don't have the microphone on. I do agree with you. I think, everybody, when you read about coronary spasm, recurrent ST elevation, maximum medical therapy, they come back. Stent is the last resort, and we do respect actually what you did. Regarding the arrhythmia, I think we have to have a documentation, of course, to put an AICD rather than doing it prophylactic. So you need a documentation, right?
My comment, actually, I think, with my respect, Dr. Rasheed, very nice case, very courage actually to present the case. Rasheed Surtwan, Habibi. Just I want to do a comment. I think everybody did his job of everything there. But regarding the anticoagulation and reversal, it depends before or after stenting. Because we do lots of cases and even CTO on these things, and we have lots of perforation. If it is before the stenting, you can reverse. After stenting, it's preferable not to reverse. This is the first point. The second point, ILS type 2, no need to do anything other than observation. ILS type 3, the first thing to do, even if you have very, very, very small or tiny pericardial effusion, to put the needle there because the disaster is coming. So these are just the 2 points, everybody just to know, because we are at different levels here. So, but these are the basic things to understand for everyone.
Thank you.
Hadi, would you allow me?
Please.
Please, Dr. Ahmed, I have a comment. You presented such a nice case of massive pulmonary embolus, and I wonder if the oxygenation was okay during Cath. Like you put him on the Cath table, most likely there was a probe for oxygenation. You didn't notice anything. That's number one. 2, it has been recommended now universally to avoid injecting dye through a tipped catheter, regardless of the chamber you are in. So if you want to prove you have a pulmonary embolus, put your pigtail in and do a power injector, because catastrophes can come from that tipped catheter going invasively into one of those arteries.
You said something which I know a lot of people in the audience might not like my comment, but I have to say it. In-hole catheters are not made for LV grams.
Yeah.
Even if you did the 20,000 of those without, I don't care about this. But if you look into the literature, believe me, my friends, there are a lot of cases of massive perforation with end-hole catheters. Don't do it. There is a pigtail, you know, and I think it's just something which is, if you want to stick to safety in terms of what you're doing in the cath lab, that's what you should do. If you get away with it for 20 years, doesn't mean that it was a safe procedure. It means that you were lucky. That's all what it means. But I agree with you. Any other comments, please? Ahmed, please, you want... please, Ahmed.
For the injector. This is valid for injector, but it was hand injection.
Yes, I know.
It was hand injection.
I think it is the same as coronary injection. You are injecting through the coronary through the same catheter, so it's safe. As long as it is hand injection, not an injector, so it's safe.
You did a great job, Ahmed. I think the whole purpose of discussing the way I see it, you know, I want to learn from you. We all learn from each other. But again, I agree with him. End-hole catheters are not made for angios, especially in chambers. I mean, you know, especially in chambers.
Yeah, sure.
But that's what we're trying to say.
The high pressure, I agree.
If I might add, even the quality of pictures you got, we depend on your expertise. But if somebody, a junior, is going to inject it with the hand, I wouldn't see anything. So a power injector will give you right diagnosis legally and for the patient consideration and right diagnosis. I mean, we saw something.
Yes,
your expertise said
right.
it's pulmonary embolism.
Yes, right, of course.
أحمد عنده زرقاء اليمامة العيون تبعته. شكرا أحمد. Any other please write.
A comment regarding the spasm. Just to remind myself and everyone that the stent is to treat the endothelium. It is not to treat anything else. For re-endothelialization in a proper way. So I think when you have a chemical-induced spasm, we treat it by chemical-induced no spasm.
Yeah. All right. So for Munther, if you don't mind, Hadi.
Please go ahead.
Hadi, Munther, thank you very much again. So in your pictures that you got, beautiful pictures, but if you look carefully at the healthy circ, it has a slow flow, which tells you that that pot with all the amphetamines in it, it's causing a microcirculatory problem. Again, going to what everybody is echoing, medical treatment still needs to go on, and stopping pot is the answer. Yeah, thank you.
You know, right, the problem is, عودة لقيس lecture, we don't have a lot of things which we like to have in the cath lab. If you want to diagnose microvascular angina in Jordan, what would you do? You just follow your hunches. That you say, والله normal, عنده angina, positive treadmill, that's microvascular. بس يعني, by science, this is not microvascular. This is because you don't have the equipment to diagnose it. Without having the proper, you know, doing a coronary flow reserve, right? Without doing IMR resistance, you cannot diagnose it. It's very difficult. Please, Ayman.
PE. Sometimes, if you can't explain with a left heart cath, you probably should go with a swan and do a right heart cath, and that will probably give you the diagnosis too.
But you know what he did, Ahmed, is something I respect and I like, is doing echoes. A lot of you guys in the audience do not do it with acute coronary syndrome and ST elevation MI before you go in with your catheters. I can tell you something, again, it's in the guidelines. It's not a class 1A. It's recommended to do an echo for everybody with a STEMI. It's a class 2A. Of course, if you can do it. Yeah. Me personally, أنا كهادي بقول لك, I do it in the cath lab لأني بعمل كله راديو. بجيب هالإيكو هم بالشبيبة بيعملوا رايت راديو بيضبطوا لي الإكويبمنت. I do an echo in every patient. And I can still remember a patient like Dr. Ahmed patient, which was on the table, and I did the echo, and the right ventricle was massively dilated. Yeah, and I stopped. I didn't do a coronary angiogram. I knew what I'm dealing with. And I remember vaguely كمان مريضة كمان قبل 20 سنة. I just did the echo and I could see an ascending aorta هالقد with a flap in it with aortic regurg. So you can save yourself a lot of trouble by doing this 2 minutes. But I respect that, Ahmed, you did it before the angiogram.
Thank you, everyone. شكرا جميعا.
Thank you.
Thank you. Is there a break, Ahmed? Mahmoud?
راح يكون في تغيير شوي على البرنامج. احنا اخر سيشن راح يكون اللي جاي هذا اللي هو سيشن 2 complications راح يكون. انا باعتقادي معاكم للساعه 5 half an hour. ريحوا حالكم، اللي بده يصلي يصلي، يشرب قهوه، غير جو، تحالفات ثنائيه رباعيه ما في مشكله. الساعه 5 بنرجع هون. بذكركم الاحسن 3 حالات راح يكون اليوم بسيشن 2. احسن 3 حالات لليونج دكتورز عندنا، واحسن للتكنيشنز 3 تكنيشنز السينيورز تكنيشنز راح ياخذوا كمان اووردد.